I would like to welcome you all to um, the Journal Club. Our CFAR Journal Club is not a normal, well, it's of course normal. It's not a usual kind of journal club where a person would present an in-depth presentation of a journal article. What we do each quarter is we ask a representative from one of our cores, either the basic science, the social behavior, or the clinical and population core, to choose an article that they find interesting from their point of view of their research and present it in a sort of overlay of the presentation. And then we ask representatives from our other two cores to read the article and think about their research and if they could find something that they might find interesting to do from their point of view of research. This, of course, we've talked about the fact that basic scientists might have their blinders on and only be thinking about basic science, and social science is the same. I'm not going to say that we're not all in any way different. We tend to look at our own interests. But what we're trying to do with this journal club is to bring people out of the box, to be hearing about a research area that they may not have read that article because it's basic science or it's social and behavioral, and think about the fact that, is there any kind of research from their point of view of their specialty that they could think of doing on that research area, or a partner to that research area, something in the neighborhood. And of course, the goal of all of this is to bring discussion, to have people talk, and maybe come up with collaborations of people, teams that never would have gotten together. We've actually been successful in this a couple of times through the Journal Club, and actually had some applications go into NIH from this. So again, it's sort of let's see what everyone can think of and maybe come up with some different areas of research for people. So today we're going to have Rachel Denier present the article, and then we're going to have Ali and Prethi give their point of views. And so Rachel will have about 10 to 15 minutes. And again, it's not an in-depth, it's really just an overview of the presentation. And then each of the respondents will have about 5 or 10 minutes, and then we'll open it up for questions or discussions with everyone. So Rachel, you're on. Enjoy, everyone.
Okay, thank you, Dr. Silva. It's very nice to meet you all. My name is Rachel Denier. I'm a relatively new faculty member at the DC VA Medical Center. And I am also involved as faculty at GW for Infectious Diseases Fellows, and I co-direct the clinic for persons with HIV at the DC VA Medical Center. So I am just going to share, I'm just going to share my slides. Okay. This is my contact information should anyone want to reach out after the presentation. And I'm just going to apologize for the fact that while I'm presenting, I can't actually see what's in the chat. So feel free to post questions, but we'll come back to them after I've finished the brief presentation. So this is the paper that we're discussing, which is treatment of anal high-grade squamous intraepithelial lesions to prevent anal cancer. By Polewski and colleagues from the ANCHOR investigators group, and it was published in the New England Journal of Medicine earlier this year. So in terms of why I found this interesting, so the risk of anal cancer is significantly higher in persons with HIV than the general population, and these are actually some summary numbers that I took from the paper itself. So 89 per 100,000 is the incidence for men who have sex with men with HIV, 18 to 36 per 100,000 for women with HIV, and that's compared to 1.6 per 100,000 person years for the population as a whole. And another reason I find this interesting is that it actually involves not one, but two infectious diseases. because anal cancer, like cervical cancer, is associated with infection with human papillomavirus, particularly high-risk types such as HPV-16. And anal cancer is preceded by precancerous changes, and the ones most pertinent to this paper were the high-grade squamous intraepithelial lesions, HSIL, which equates to anal intraepithelial neoplasia 2 and 3, because there are multiple different ways in which this can be graded. So right now, in terms of screening for anal cancer in persons with HIV, we can screen for precancerous lesions for these higher grade HSIL, AIN 2 or 3 using either an anal pap smear or anal high resolution anoscopy. But in terms of screening guidance that we follow, it's pretty weak. So the 2020 HIV Medicine Association update said that persons with HIV with a history of receptive anal intercourse or an abnormal cervical pap test, and all persons with genital warts should have an anal pap test if there is access to appropriate referral for follow-up, including high-resolution anoscopy, if those things are available. But there are no national screening guidelines for the use of anal pap tests. So this is really a conundrum for those of us who manage treatment for persons with HIV and provide primary care for that population. And prior to ANCA, we didn't really have good evidence as to whether treating these precancerous changes, the HSIL changes, prevented progression to anal cancer. So this study had a very large number of participants. There were over 10,000 individuals assessed for eligibility. And one of the other reasons I wanted to talk about this is that some of our clinic patients actually volunteered to participate in this study as well. And at baseline, as I show on the left-hand side of this slide, all potential participants underwent an anal pap and high-resolution anoscopy, and they were eligible to enroll if HSIL was found on either of those tests. And they found HSIL, these high-grade precancerous changes, in 55% of men who were screened for eligibility, and 47% of women, 67% of transgender individuals. So actually really a large number of those that were assessed for eligibility. So showing the consort diagram on the right, the most common reason for exclusion was the approximately half of persons that didn't meet the inclusion criteria, either because they received a diagnosis of anal cancer or because they didn't have the correct sort of high-grade precancerous changes on their initial screening. 4,459 underwent randomization. And what's really impressive about this study is that very large numbers of these were retained, were still involved in the trial at the time of closure. There were very few discontinuations and losses to follow-up in either arm. The intervention was randomized 1-to-1 within 12 weeks of that baseline screening high-resolution anoscopy. The treatment group had immediate treatment of those high-grade changes. That could be ablative procedures, and in most persons that was electrocautery ablation, could be excision, could be topical treatment with imiquimod or fluorouracil. And then that group received high-resolution anoscopy as needed for their treatment protocol, but at least every 6 months. And then the other group was the active monitoring group, which just received high-resolution anoscopy every 6 months without any intervention to those high-grade precancerous changes. And the results, I think this is the key result really from the study, is that the treatment group had a lower risk of progression to anal cancer, which was significant with a p-value of 0.03. And you can see from the Kaplan-Meier curve here that really those two groups do diverge. And I think this is a pretty impressive result. Other results that I thought were important to highlight: the rate of progression to cancer was actually much higher than was expected, I think, based on the numbers in the literature. in the past. So the treatment group had a rate of 173 per 100,000 person years, and the active monitoring group a much higher rate of 402 per 100,000 person years. This might to some extent reflect individuals volunteering themselves for this study who might perhaps be more likely to have had abnormal screening results in the past or have higher incidence of HPV-related warts, for example, than say persons seen in primary care that might not have stepped forward to volunteer for this study. I just wanted to highlight the adverse events as well, which were more common in the treatment group when it comes to trial-related serious adverse events, but I still feel we're well within what would be acceptable for a cancer screening study with a benefit in terms of progression to cancer. In terms of the implications for my research and practice, this helps in terms of the lack of clear guidelines for anal cancer screening in persons with HIV, but it's progress, but it doesn't really fix that problem and that deficiency in the guidelines. So it doesn't really tell me how often we should perform an anal pap smear, who exactly we should refer for high resolution anoscopy. So for example, the ANCHOR study included only those with high grade changes. It doesn't address what we do regarding those with other abnormal anal pap findings. So with LSIL with lower grade changes or atypical squamous cells of uncertain significance. And I don't know how we feasibly implement this. I see this more as a proof of concept study that says, yes, if you treat the precancerous changes, they're less likely to progress to cancer. But it doesn't tell me what I should do with patients in my own clinic in terms of screening or referral for HRA, because there simply wouldn't be enough HRA trained providers for all persons with HIV to undergo Q6 monthly high resolution anoscopy. So it really highlights deficiencies in the cancer screening guidelines. And then the last question that I have, which comes up in clinic quite a lot for me and is something I wonder about, is the potential modifying effect of HPV vaccination on anal cancer risk. And as things stand, it's recommended that younger individuals receive HPV vaccination. It's thought to be most effective before people are exposed to those high risk HPV subtypes. But I do think that there is a need for studies that address any protective effect of HPV vaccination in terms of progression from precancerous changes to anal cancer. And I think that's an avenue potentially for future research. So I think I will stop sharing my screen at that point.
Thank you, Rachel. That was very good. Very good.
And I want to hear what others thought of this paper, because I see it as a really interesting proof of concept study, but a long way from where we need to be in terms of implementing this as evidence-based cancer screening guidance.
Yeah. Thank you. I was going to say it was very interesting from the clinical and population science point of view. Let's hear now from the basic science point of view. Allie, do you want to respond?
Oh, sure. From the social and behavioral science perspective.
And behavioral, I'm sorry. Okay.
No worries. And I appreciate you sharing, Rachel. Interestingly, or maybe not that surprisingly, I have very similar perspectives, and you'll see that in my PowerPoint presentation I'm about to share. Okay, so let me just share my screen. And can folks see this? Let me see if I can put it.
Yes, and Allie, why don't you introduce yourself, please?
Sure. Can folks still see my screen?
Yes.
Okay, great. So hi, everyone. My name is Allie Talon. I use they, them pronouns. I am a research scientist at Women Walker Institute and am particularly interested in social and structural barriers and facilitators to the HIV care continuum that ultimately contribute to health disparities and inequities among gay, bisexual, and other men who have sex with men. So as I just mentioned, I'm going to share some of my thoughts about the anchor study findings from a social and behavioral science perspective. So I was really excited to read about the anchor study, the study design, and its findings, which found that similar to cervical cancer, anal cancer can be prevented through the screening and treatment of known cancer precursors. And these findings are, from my perspective, really important just due to the dearth of research on the relationship between the treatment of anal HSIL and the incidence of anal cancer. And so the fact that this study exists, I think, is the beginning of something really important. And I'm just going to go to my next slide. So I'm showing something very similar to what, to what Rachel just presented in terms of anal cancer and HIV prevalence. So when I was reading the article, I was thinking about the populations that are at greatest risk for anal cancer, and those include gay, bisexual, and other men who have sex with men, people who are living with HIV, as well as trans women. And so as you can see here, the incidence of anal cancer is estimated to be 89 per 100,000 among men living with HIV who have sex with men, and then between 18.6 and 35.6 per 100,000 for HIV positive women, and then comparing that to 1.6 per 100,000 among the general population. Interestingly, so this study is exclusively focused on people living with HIV, which is really important because people living with HIV face health disparities compared to the general population. But in a separate research study, they found that HIV negative men who have sex with men have anal cancer is estimated to be 5.1 per 100,000. So even when removing the HIV, there is something going on with sexual orientation or sexual behavior. So I just wanted to highlight that. And let me just go to my next slide. So something that I was really focused on, which I think Rachel brought attention to, is the lack of screening guidelines. So when I was thinking about how this could be implemented in a real world setting, I'm really interested, as I mentioned, in barriers and facilitators along the HIV care continuum and the ways that folks living with HIV can reach viral suppression so when they're engaged in care. And so there are really, I think, relevant opportunities for the integration of consistent anal screening within the HIV care models. And when I was thinking about this, what I think would be really helpful, which I don't think is necessarily quite easy, is to have those who provide care for people living with HIV really to be the ones that champion and advocate for screening. So Rachel alluded to the HIV Medical Association, which does have some screening guidelines. But that said, looking nationally and across different medical associations, there isn't really consistent guidelines. So I think that really is a big limitation and something that really needs to be addressed to see any meaningful change in terms of screening and treatment of anal cancer among folks living in the United States. And so I am looking forward to seeing the ways in which maybe some national screening guidelines change. Just within the past month, when I was preparing for this, did read some work that came out of New York State that actually referenced this article and is making some changes to their guidelines, but that's at the state level. So seeing some larger changes is something that I'm really looking forward to. And, to date, thinking about how we might get there, conducting pap smears from my research is, something that is perhaps easier to integrate into primary care practice and among HIV care providers, but providing that high resolution endoscopy is far more difficult, which also Rachel alluded to, and to have robust training and expertise and the ability to refer folks, especially depending on where folks live across the country. I do see that as a really big limitation for really ultimately reducing the rates of anal cancer among people living with HIV. And also just making sure that nationally, the insurance companies are up to date. So folks do get denied for anal pap testing, even when they're living with HIV. And that has happened even over the past couple of years. So making sure that when people indicate that they want to be tested, the providers do anal pap testing. We don't want to see additional barriers, including some financial ones there. So really, that's kind of where my head was at. I agree with Rachel that this is a really important work, and within a study context, you see reduced rates of anal cancer among those who are getting screened and receive treatment for HSIL. But I do think in terms of, the real world implications and looking in real world settings, that there's going to be a lot of work that needs to happen across the providers at the systems levels, insurance companies, to ensure that folks who are at risk for anal cancer are receiving the preventative care that they really deserve. So that was sort of my take on the study, and I'm happy to chat more with folks after we go to the basic sciences perspective.
Thank you very much, Ali. And yes, let's go to the basic science perspective now. Prethi, would you introduce yourself and start sharing your screen?
Sure. Hi, everybody. I'm Preeti from Howard University Chemical Engineering. This is my first time in this journal club presentation, so I didn't know I had to have a presentation prepared, but I did have thoughts on it, and I approached this really as not anybody, as someone who doesn't do any clinical science. I'm very like biophysics, so it took me a while to even understand like what was going on. I have to be honest, I had to like look up the mechanism of HPV and stuff. So, but this is what I thought about the paper, and maybe you could help me understand it too. So the thing that really caught me about this paper was the relatively high incidence of anal cancer among people with HIV. Excuse me. And I was looking up at the causes of anal cancer a lot, and a lot of it also seemed, well, since the a lot of it seems to be related also with the immunosuppression. Like the HPV is more like virulent when there's immunosuppression. So and I was thinking maybe that could be a reason also why it is its incidence is higher in HIV related patients. But interesting is like when I think about HPV, I always think about women and cervical cancer. So the fact that it occurs more in men to men, which is about like twice as more likely, was very interesting. So the question is, was it like behavioral, or was it just the nature of how this happens? And I was a little intrigued by that. I went and looked up a little bit. I had to do this because I don't do any clinical related work, and I had to like sort of educate myself. And so apparently this squamous epithelium is around here, and it's where like most of the infections and the lesions happen. And a lot of the progression seems very similar to cervical cancer. And the HPV virus, apparently it changes the cell cycle of infections, changes the cell cycle of the cells, causing them to be more cancerous. So it made sense to me that the treatment has to be ablation that is basically removing the cells because there's no other way you can get the virus out, or adding some, you know, chemicals that will that will kill cells that will kill cells that are rapidly dividing. So that made sense. But forgive me about my dog, but the thing that really struck me about this paper was, even though it started with anal cancer being high in HIV, I didn't see any relationship in the outcome of the treatment with either the CD4 levels, which means if the CD4 levels are indicative of the level of immune suppression you have, and the HIV RNA levels, if that's an indication of the viral load you have. So I was a little, and maybe I didn't read it right. I was a little curious why there was no association made or if there was a greater incidence of the transition to cancer when you're more immune suppressed, or if your viral load is higher, even though they seemed to have a range of patients with a range of these two characteristics. And this is where, because I didn't know, like, if the greater incidence of among HIV patients was because of the immune suppression. And again, I'm not from this, I'm a very biophysics person, so I have to look at mechanisms. So this is how my brain thinks. So I might be thinking wrong, but I thought I could open this up for discussion, just educate myself like that. So in that context, what really I feel I could take to my research is more among like how the mucin traps the HIV virus. So I'm looking more into like if there's changes in the mucin that changes how the virus gets trapped, and it points me to like, is there changes in like how it traps the HPV virus, or is there like systematic changes in the mucin in HIV individuals? Which is why I was kind of looking at the CD4 levels in my understanding, just to see if the immune suppression did not contribute to increased progression to cancer in HIV individuals. Could it be that there was a greater incidence of HPV transfer in these individuals because of the mucin levels and stuff? So that was an angle I was looking at, and which is why, yeah. Thank you for like accommodating me, and I look forward to hearing what you say.
No, Prethi, that I appreciate the fact that you went into this cold like that. I did not realize that, and I apologize, but I think it was really interesting, because I think you did exactly what we were hoping for this journal club, is the fact that you came at it from your point of view, and you did a great job. Now, I have to refer to the people that know. I mean, she asked some questions. Rachel, Ali, can you answer them for her?
Can I start perhaps by addressing the issue about CD4 count and HIV virologic control, and then maybe, Ali, would you be willing to answer questions about maybe behaviors and how they might contribute to anal cancer and HPV? In terms of the CD4 count, I believe what's reported is actually the nadir CD4 count in table 1, which is the lowest CD4 count that somebody had historically. So it's not the current, they do also report the current CD4 count, but the nadir CD4 count is an indication of how extensive their immune suppression and how advanced their HIV/AIDS was in the past, not necessarily where they're at now. And as you get into some of those, as you get into the groups with higher viral loads in this study, who are not suppressed at the time they're participating in the study, there's really only a very small number of individuals in those groups. So it's, I think, 5.5% of the treatment group have a viral load of over 1,000. So I wonder if part of the reason for not seeing a sort of dose response relationship between HIV virologic control and progression to cancer is just that most of these will be patients in care on ART with relatively well controlled HIV, and the numbers who are uncontrolled are very small. And then in terms of the current CD4, when they're participating in this study, the median was 602 in the treatment group and 607 in the active monitoring group. And the interquartile range was around about 400 to 830. So these are on the whole a very well controlled patient population.
So in the sense that there was not a range of data for them to work with to make any correlative analysis.
Exactly. There were very few patients in this relative to the study size as a whole who had who met criterion for AIDS in terms of their CD4 count and had uncontrolled HIV viral replication.
So as a whole on the in the population, what about screening? Were there statistics on vaccination? Were these an older group so that vaccination was not part of it?
There's no data on vaccination, and I really would like to see that. And I wonder how much of that is that I suspect participants in this study, it's possible that the providers seeing them for high resolution anoscopy, who may well be GI specialists rather than their primary care doctor or infectious diseases doctor, may not have had complete information about their vaccination records. So it's possible that the authors didn't know. It doesn't seem that that information was collected. And the median age was 51 in both treatment groups. So most of these individuals would have been too old to have received HPV vaccine. But I really would love to see data comparing a younger and an older population group, or comparing those of the same age who were vaccinated versus unvaccinated. But I doubt that data was available to the authors of this study.
And what about the question of screening? Now, this would hopefully be what a landmark study to be able to give some oomph to the policymakers, or of course, how long are we talking about before we might see something like that? But Ali, I think you mentioned that, right?
Yeah, and then beyond just creating the guidelines, I feel like there are like implementation issues, and also the uptake among providers across like different regions and their own maybe like biases. So even if the screening guidelines are there, we have seen with other types of infections and disease, there are like clinician level barriers that can come about in terms of ensuring that they're adhering to the screening guidelines as necessary.
So let's open this up to everyone. I mean, you know, from what we've heard, and is there anyone that has any thoughts on possible research to be able to give some oomph to any of the issues that have brought up, like, for example, screening guidelines? Is there anything that people want to mention or talk about with that, or just bring up? I'd like to hear from the people on the call.
Dr. Lucar, I can see that you had a hand raised.
Hi, Rachel. Hi, everyone. Can you hear me okay?
Yes.
Thank you. My name is Jose Lucar. I'm an infectious disease physician, such as Rachel, and have a practice in people with HIV here at GW MFA. I had the exact same question as Rachel had in terms of the HPV vaccination. So I just built the protocol. They seem to have excluded people with vaccination, which is, you know, seems to be very, you know, part of what, and I think Rachel and I kind of are thinking in a very similar way. You know, who should be screened? Like, what criteria do we use considering the limited resources? And then the other thing that is interesting for this study is that they only started recruiting people at age 35 and older. So this is very reflective of seems to be a very specific, you know, subpopulation that we care for, which are somewhat older, and vaccinated. subjects for HPV. So whether it's I find quite remarkable that 55% of those had HSIL or HSIL, which is really, I think, a call to action. I had to read it like 3 times to realize that. But yeah, so I think this really, like I said, in adults who are 35 years and older who have not been vaccinated against HPV, if we're going to find that 55% of those have HSIL at baseline, I think that's a population that certainly would warrant screening at least once. But once again, the next question is, how often do you screen them? You screen them once a year. I know that some of the authors of this paper who write some of the review articles suggest once a year in persons living with HIV who have, particularly men who have sex with men. Is that realistic? Is that feasible? With, as Rachel said, with the number of providers that offer HRA every 2 years, I think there are clearly implementation questions, as Ali was mentioning, that I think have to be taken into consideration. Are these people getting deals from their insurance companies that where some of these are not being covered? And then the last thing I wanted to mention is where does HPV testing play a role here? Are those who have HPV DNA negative, are those people who you can, say, make a different kind of recommendation? I think those are all questions that remain unanswered, but, thank you for that time to be able to speak.
David?
Hi there. Thank you all for hosting this. I was super excited to see this article come up in the Journal Club, and thanks for hosting a really thoughtful discussion. One thing I just wanted to add to the mix, I think Rachel brought this up, and I think it was a really good point, is not only do we have enough providers to provide this HRA, but then what do we do with the results of the screening, specifically in terms of how aggressively do we treat these things that we find? Because when you screen more, you're going to find more, which is good. I have some colleagues at Kaiser in Northern California. We've been working on a grant proposal to study some of this stuff, more the outcomes of different treatments for different levels of dysplasia leading up to cancer. And one of the interesting things that I've learned is that there are no clear lines in the pathology necessarily in terms of where high-grade dysplasia actually becomes cancer. Is it a couple of cells? Is it what's the definition and what are the recommended treatments? But one thing I'll note just for the clinicians, and also I think for those of us who study these issues, is that anecdotally what's been documented is that as soon as something sounds like cancer, the treatments get very aggressive very quickly. And particularly when the treatments are not those that are performed through HRA. So this study was conducted in the context where there was a community advisory board, there was a lot of input from the community, and the treatments were very carefully sort of vetted and monitored by that advisory board. What we see anecdotally in the practicing community is that somebody like an infectious disease doc will hand off to we'll say oh, I see, we see some dysplasia, we see an abnormal result, and then they hand off very quickly to surgeons, and what surgeons like to do is cut. And so then we see aggressive excision in people who have maybe a few, maybe a relatively low grade dysplasia. And so and the thing it's almost virtually completely ignored in all of the treatment for anal cancer, whether it's low grade or advanced, is the fact that the rectum is that this region is a sex organ for gay and bisexual men. And anecdotally, the treatments are quite, are pretty destructive, particularly the more aggressive treatments. And so, it's just sort of the last thing I'll say is that we, have been talking to patients and talking to them about their experiences, and this is completely ignored, and it's not ever ignored when you look at other sorts of treatment. If we were talking about treatment for any other kind of cancer, these psychosocial, psychosexual realities would be included in the treatments, particularly things like for prostate cancer, breast cancer, those are treatment considerations. How aggressively do you want to treat given the impact this is likely to have to your day-to-day function and the aggressiveness of the cancer? And that's completely missing from these conversations currently, particularly outside of the context of this study where that community advisory board was pretty heavily involved. And so my fear is what this is going to lead it to is more screening and then more handoff to providers that aren't equipped to do this, more aggressive treatment and more side effects, some of which are pretty debilitating. So we've been working on a study to document some of those side effects to like create at least a little bit of concern and a little bit of precaution when it comes to recommending aggressive treatments across the board.
So it seemed like though, let's see, I think it was, I don't know whether it was Rachel or Allie who was saying that we should really try to increase screening, that we should have a way of having the providers provide more screening. Was that correct?
I think it's a balancing act. I mean, David raises really good points in terms of the implications of like over treating or and what happens there. And I do think that it goes back to just like the knowledge and understanding and having experience. So when there is anything like new, there is obviously, it takes time for folks to become competent and then implement and then know when is maybe like too much. And so what David is talking about, I think is definitely something that like will happen and already has happened in terms of handing folks off to experts who might not take the full picture of the person, and not even just like the physical health outcomes that David was referring to, but also the mental health outcomes that's associated with these really invasive procedures that have, you know, lifelong implications. So I think it's a balancing act to ensure that folks who, if we have the screening and we have the treatment, making sure that it's being done effectively and efficiently and really centering the person at hand. And all of that takes like very thoughtful, collaborative working teams and the realities of like everyday environments, I don't think is really there right now.
Is there anything?
Oh, I just want to be clear, I was not advocating for less screening. I mean, I think this has demonstrated the benefit of screening. The challenge, though, is when you screen, you have to then have like really rigorous recommendations for what you do with a positive result. And that's what I think Rachel pointed out we're missing. And one of the things, so I think there's a ton of room for research in a clinical area there. And one of the things that should be included in that is like not just what treatments are effective, but what treatments are effective and spare important kinds of function, you know, the kinds of function that are important for these gay men continuing to live their lives in a satisfactory manner.
And I was going to say, is there anything that, and we're talking about research, of course, and we're talking about trying to do HIV research in this within the CFAR. Is there anything that we can try and do as far as, you know, helping to identify issues or make sure that providers are aware of them, or find out what providers are lacking and try and I mean, does anyone think of anything that we could, you know, or that anyone could try to do to bring something to the knowledge of the community or the providers related to some research from the CFAR?
I think there's the potential for some research to identify barriers from a provider perspective to screenings. So, for example, one of the barriers in a primary care setting can just be the time that it takes to do an anal PAP when you have maybe 20-minute appointment slots. It may be insurance reimbursement, it may be a fear of patients, especially new patients, disengaging. I know that I often don't bring this up at a first visit with a patient. I wait for a second visit so that I have some rapport and some buy-in from them for what's an uncomfortable and, you know, it's an uncomfortable and fairly invasive thing to do an anal PAP. I think that there's probably room for some qualitative research to find out what what persons with HIV think of these screenings and how acceptable they are, and particularly, as David Hubner was saying, you know, how acceptable some of the more invasive treatments for HSAL are, and whether there are a certain preferences for one treatment over another, but also about the provider and systems level barriers to actually implementing anal pap screening more widely, and certainly HRA. So for example, from our clinic, I know that one of the barriers we have to referring people for HRA is that we don't have a provider at our facility. We go through a administrative process to get VA to pay for community care referral to a private practice that actually was part of the anchor study with Dr. Corman usually, for them to receive that treatment. But there's certainly a loss to follow up between us sending a referral for an outside provider, it going through this administrative process, being approved, and the patient actually being seen. And I feel like we see losses every step of that way. And I face, you know, reluctance on the part of patients to go see a provider they don't know, especially about something with so much stigma attached to it as anal cancer screening. And that's going to be a provider they don't know, who's going to probably ask them questions about sexual behaviors that they may not feel comfortable discussing. I feel like there are barriers, even though we don't suffer from the insurance reimbursement issue. There are still a great deal of barriers to patients actually being seen and having appropriate screenings that aren't really covered by this study, but have implications for guidelines for screening.
Wow, sounds like a quagmire. Absolutely. Anybody have any other comments? Yes, Anne.
I think that one of the things that would be interesting to do more research on is really trying to figure out who's going to progress, because these are invasive. It's very time intensive for the patients, for the providers, and you know, many of them are probably unnecessary because these people aren't going to progress to cancer anyway, right? I mean, the absolute number of people who actually progressed to cancer in both groups in the study was very small. And so I think this is like one of the problems we have with many different conditions is we just don't know who's going to do badly. So it would be great if we could do some research to figure out who really needs, you know, the most aggressive levels of care versus who would be okay with less frequent follow-up, like perhaps the people who are HPV negative, even though they have HSIL, maybe they could have less frequent follow-up. So I think that would be an area for research.
And the historical context here is that these are, you know, these were the less aggressive treatments, you know, relatively, you know, before there wasn't a lot that we offered. We sort of waited until it progressed because so few people did progress. And once it progressed, then, and it was highly treatable, but it was just very aggressive treatments. And so this was a consideration like, well, we do a lot of people with lower level treatments, maybe we can make an improvement, and it worked. Now the question is like, who's going to be able to provide that level of, you know, thoughtful care at scale?
And I think, I mean, you know, having had a couple of members of my family have to go through multiple medical procedures lately, it's just that asking people to do this so frequently, and the preparation that's involved, and the, you know, the time off work they have to take, and I mean, I just feel like as a provider, I have become more aware recently of what I'm actually asking people to do, because I know what an impact it has on my life to try to do everything that I'm asked to do for myself and for my family. And so it's just, I think we have to be like, what is really, really important, you know, getting people to take their HIV meds and getting them to stop smoking, right? And so I don't want to like diminish the impact of this study. I think it's really, really, really important. At the same time, this is, you know, I do anal paps and I refer people and I do what I'm supposed to do, but I just sometimes wonder, am I actually like moving the needle on this anal cancer? Or is it the worried well who keep going and the ones who are never going to get anal cancer anyway? So I don't know. That's my conundrum as a practitioner.
Any other comments? Alan?
I mean, just a process comment. I've really thoroughly enjoyed this very informative discussion. We really do seem to have a critical mass of very smart people who are very passionate about this issue on this call. We have clinicians from Georgetown and GW and the VA and perhaps other, certainly Whitman Walker's very involved in this issue. And you've got social scientists from different institutions and who've sort of come together, and I'm not sure if everyone knew each other before this call, and I'm not suggesting a path forward. I know we have the aging and comorbidities SIG now that can pull people together, but there does seem to be an opportunity to have some follow-up in-depth conversations on this topic that we could help facilitate.
Yeah, that's true. We will facilitate if anyone wants to get together or ask a group of people to get together, please just let us know. We will facilitate that. Vivian will set up calls or anything like that. I mean, you know, the thing is that it's there, the whole aspect of anal cancer, HPV, HIV. You know, the thought today is that we really don't know where it's going to go and what we can do. So the thing is that we want to foster collaborations. We want to foster HIV research. That's the whole goal of the CFAR. So please, everyone, think about it. If you have any ideas, either get together with someone you know, but if you need any assistance, please call us. We will facilitate that. Does anyone else have anything else to say? We're getting close to the hour. I think it was a very interesting thing. Thank you, our presenters, Rachel, Preeti, and Ali. Thank you very much. And again, if anyone would like to follow up with anyone, just let us know. Okay? Take care, everyone. Thank you very much.
Bye.
Thank you.
Bye.
Thank you.
Bye-bye.